Good evening, friends, and thank you again for joining this monthly webinar. And we are having a very interesting, very practical, very common topic, which is dear to most of the pediatric hematologists and transplant specialists, and that is on the primary immunodeficiency, which is the IEIs. We had a wonderful session already, a talk on how do we prepare those patients prior to transplant, and that I think is one of the very important aspects of transplants and IEIs, and that's been wonderfully covered by Dr. Yogi Raj from SickKids, Canada. Now, we're going to have some practical aspects which are to be discussed, and that is to be in the Indian context, and that's what we usually do in these webinars. We'll have a talk which is a little broad based, and then we will discuss the nitty gritties of that important topic in Indian context. And we have none other than Dr. Manas Kalra, who is a senior consultant at the Department of Pediatric Hematology Oncology at the prestigious Sir Gangaram Hospital. He's also currently the secretary of the Pediatric Hematology Oncology chapter. He's going to be moderating this session, and joining him are Dr. Yogi Raj. Thank you very much for staying back, for being part of this panel, and he's been introduced already. Briefly, he's assistant professor and staff specialist at the Sick Kids for Children at Toronto. Dr. Mohammed Ramzan, already been introduced. Just briefly again, he is a staff specialist at the Pediatric Hematology Oncology Unit at Burjeel, the Medicity at Abu Dhabi. And Dr. Anand Prakash, my friend here from Bangalore, who is a senior pediatric hematologist oncologist and professor and head of pediatric hematology oncology at the prestigious St. John's Medical College, Bangalore. All the experts on this panel have tremendous experience in managing IEIs as well as transplanting IEIs. And I think Manas is going to take us through the more practical aspects of and our Indian scenario. What are the challenges we face? Thank you very much, Manas, and over to you.
So, good evening, everyone. I hope I'm audible. And, I thank the organizers for this opportunity. I'm going to talk about primary immunodeficiencies in India along with these esteemed panelists. And my whole discussion is going to be a little case-based. I'll present a few cases, and then you'll take questions from our panelists. We'll give Yogi a little bit of a rest from speaking. He has beautifully presented this, how we should prepare these patients pre-transplant. It actually made me nervous because half the drugs are not available for us. So I'm still wondering how we in India are managing these children with IEI and somehow, trying to do a reasonably good job. So Yogi, you will have the last case will be to you. And Ramzan and Anand, the first two cases will be directed to you. But please feel free to give comments, all three of you, whenever you feel that we are missing on any important point. Please give your comments on that. Ramzan, I was struggling to hear you, so if you could just come closer to the mic, that would be better, because the first case is directed towards you. So this is a male symptomatic since 6 months of age, recurrent infection. There was failure to thrive. There was no significant family history. And I just quickly rushed through the cases because, we have a lot to cover. And in the January of in 2024, this baby had baseline tachypnea. He was treated on OPD basis multiple times. And by May, this baby was 11 months old. He had received multiple courses of IV antibiotics. Someone did a CT, which found multifocal consolidation with the ground glass opacities. And in the June, this is, I think, the next month, there was BAL, which showed Klebsiella. There was rhinovirus positivity. His blood CMV was very high. There was non-resolving pneumonia. And at that time, this child was evaluated for a possible immunodeficiency. And, this is what the typical scenario of India is. We hardly see any patients at 2 months of age where, we are able to transplant for SCID. So, that would be the nicest thing to do, but unfortunately it isn't. So we need to just deal with what we have. And the lymphocyte subset showed severe lymphopenia, T minus, B minus, NK plus kind of scenario, and there was pan-hypogammaglobulinemia with very low IgG, IgM. This baby was started on IV ganciclovir at the primary center. It was not really the primary center. The baby had changed many centers. But yes, the baby was on IV ganciclovir. I must compliment that center in Haryana where they did all this basic treatment, gave IVIG. The general condition improved. The CMV copy started to decline, and a whole exome sequencing was sent, which showed a RAG deficiency in this baby, and a diagnosis of SCID was made. So, a very impressive workup that was done there. But by the time the baby came to us, the baby was 14 months of age with all this infection that baby had already suffered. There was no match sibling, there was no mud donor. Baby was planned for a haploidentical transplant from the father. So, Ramzan, we have already touched on this, but could you just briefly go through for our students what all pre-transplant prep you would do for such a patient in India? What is practically possible?
So I think we are dealing with the case of IEI, right? So Dr. Yogi has already covered with a nice talk in terms of regarding how to prepare the patient prior to bone marrow transplant. So in India, you usually know that patient usually come late to us. And just if I take your case, like your case was diagnosed as age of like 7 to 8 months and or so on. If the child is having some kind of infection and if child is having like IEI, we have to start like on antifungal prophylaxis, depending on your institutional policy, like whether it is itoconazole or it is fluconazole or it is posaconazole. And in terms of PCP, we have to start the safety. And if child has already received the BCG, so it is said that we have to start on INH and rifampicin 2 drugs. And if it is like it is already having that BCGitis in our scenario, so then you have to start like 4 drugs of ATT along with that. Along with that, child has to receive like irradiated blood products to prevent like graft versus host disease later on when child came for bone marrow transplant. IVIG has to be given and the level has to maintain like more than 5 would be enough. And we have to take care of the nutrition part, which is most important in terms of IEI. And you have to take care of the funds along with the psychosocial supports, and the social worker has to be involved in all these cases.
That's right. So thanks, Ramzan, for highlighting this. And, really stopping breast milk does not make much sense. The baby already has CMV, and most of our Indian population has CMV. We might be throwing this baby into malnutrition in case we stop that. So, that would be a basic care. This child is already failing to thrive. We would give IVIG, aggressively treat the infections. By the time the baby came to us, the baby was tachypneic, tachycardia was there, saturation was low. The baby had rash, and also there was bilateral crepitations. You can appreciate this rash at various stages by the time the baby was referred to us, and this horrible x-rays. There were many x-rays and CT scans which actually showed that there was a lot of pneumonia, and we were not really winning with this baby who had a SCID with a RAG deficiency. So Ramzan, how would you proceed planning transplant for this child where there is no donor, match donor in the family, and that research also has not revealed a donor?
Then only option remaining is like haploidentical donor from either mother or father, because the mother is more chances of having like maternal T cells in their system, so better to choose the father as a donor. That would be a wise option. So in terms of PCR alpha beta depletion with PTCY, both options are feasible, but depending in particularly of your case, like who is already having that CMV, viremia, and pneumonia, we have to choose the method which can cause like early engraftment of the stem cells, which can prevent like later on all the viral pneumonias and all that. So both methods are having their own like pros and cons. PCR alpha beta obviously is a costly affair. There are less chances of GVHD, but there are more chances of like graft failure and mixed donor chimerism in that. On the other side, like PTCY, there are more chances of acute drug toxicity, but at the same time, they are also having more chances of acute GVHD, but there are less chances of mixed donor chimerism and all. So yes, both feasible, but it is very tricky, and depending on the center expertise and managing all the complications post bone marrow transplant, you can choose accordingly.
So thanks, Ramzan, for that. So, I would encourage the students to go through this important paper, which has compared TCR alpha beta with PT psi. In SCID per se, if you look at SCID per se, there was not much of a difference when PTCY or TCR alpha beta was applied. And, both the outcomes in both the scenarios were similar, but you can definitely see that the curve of TCR alpha beta was a little higher in this particular cohort. If you compare non-SCID patients, this paper did show that there was a significant improvement with TCR alpha beta as compared to PT-Psi approach. And Ramzan has clearly highlighted that if you use PT-Psi, there is high chance of less chance of adenoviremia. The advantage of PT-Psi is lesser adenoviremia you will see with the PT-Psi, whereas if you use TCR alpha beta, the overall survival for the entire cohort was better. There was lesser GVHD with TCR alpha beta, faster engraftment, and lesser infections and VOD as compared to PTSI. But having said that, we need to acknowledge the fact that in this paper, organ damage was more common when people were using PTSI. So it was higher chance of organ damage, and also the pre-transplant infections were more in PTSI. And I think there was also a country bias where TCR alpha beta was used as compared to where PT-Psi was used, which could have affected the outcomes of these patients. So this particular baby, yes, Anand, you wanted to comment something?
Yeah, Manas, since we're talking about SCID and we are comparing the two platforms, I just wanted to get a sense from all the experts here and the other panelists. What is the youngest age they have used PTCY in a haplo platform? What is the
Yogi,
youngest age? Thank you.
Yogi, would you like to comment, please?
Sorry. Yeah, we only use TCR alpha beta depletion because as I mentioned, like we are doing transplants very, very early, like 3 months, 4 months of age. So we are definitely hesitant in using the PT-Psi platform in that young children.
Satyendra, your
Yeah,
comment?
Anand, we have used it as early as 6 or 7 months.
Six
But
months,
when
yeah.
you do it after 2 years versus less than 2 year, the PTSI is easier in after 2 years of age. It's very tricky in the first year, particularly, but in the first 2 year, very difficult, lot of mucositis, lot of problem, but we have done it and it is feasible. We can do it.
Okay, so older the better. So this particular baby, we was admitted for transplant at 15 months of age. CMV PCR was negative by that time. We chose to do a FTT-based conditioning. PBSC harvest was done, and cyclosporin was started on day -1. Stem cell infused TCR alpha beta, 15 million per kg cells were given. The baby had some problems, fever, loose stools, the usual scenario post-transplant. There was CMV reactivation by day 7. Baby had some hypertension. Baby engrafted by day 13. We actually used ganciclovir peri-engraftment, which is scary. And, I would caution the juniors, against using this, because the ideal drug would be to use something like foscarnate in that situation, because the graft is really coming up at that time. By day 20, the baby's distress, kind of worsened, although the baby had engraftment, which kind of settled later with regular physiotherapy, nebulizations. And really speaking, throughout this baby was on oxygen while the transplant was going on, and only later could be weaned off. The course of CMV can be seen in this, tabular column, where the CMVs went up to 1500, 1900, and then gradually started going down. So, Ramzan, what is the best time for transplanting a SCID? Very briefly, because some of these have already been touched upon. And what are the key factors that affect the outcome?
Yes, I think Dr. Yogi already showed one paper by the PI et al. Like it is less than 3.5 months without any kind of infection. This is the best time to go for the bone marrow transplant. Then the key factors that affect the outcome mainly is the age at transplant, which I already told, like less than 3.5 years, donor type, which whether we are trying to use that massive donor, mud donor, or any kind of haploidentical transplant. Conditioning regimen, whether all skid needs conditioning or some skids need conditioning, and their side effects also. And infection at the time of bone marrow transplant, those children are having infection at the time of transplant, having worse outcome. And also depending on the pre-existing organ damage, like those who are having organ damage previously during the transplant, they do worse. And in terms of phenotyping and genotyping also, like T negative and B negative and NK positive, they usually like RAG1 and RAG2 and Artemis, they usually do worse in terms of like overall survival. And yeah, so these are the
Yeah,
main
so
factors
yeah,
that have
so
to.
Ramzan has covered most of the points where we would say as to where we would like to get the edge over the diseases, early transplant, free of infection, before organ damage, and the outcomes, previous outcomes did show that mismatched related transplants had an inferior outcome. But mind you, these are older data, and Yogi already showed that this was published in 2014, but had older patients into this cohort. Even the European cohort showed that pre-transplant infections were associated with poor outcome. Earlier transplant was better, and impact of the donor showed that if you have a matched donor, the outcome is clearly much better as compared to mismatched donor. And as far as the genotype was concerned, ADA deficient SCID, IL-2 receptor, JAK3, IL-7 receptor had better outcomes as compared to the RAG deficiency SCID or the Artemis SCID, or others which were clubbed into one particular group. So, Ramzan, we have looked at all these aspects in this baby with SCID. What protocol would you recommend for transplanting this child?
So the protocol depends on your expertise mainly, what kind of donor you are going to choose, what type of disease is he having, like pre-existing morbidities.
No,
Like
we are
if child
talking
is
about our
absolutely fine.
patient. We are talking about our patient. So please focus on this baby. What would you do?
Yeah, so your child was already having like CMV pneumonia and pre-existing disease like CMV and all that. So in that situation, better to use like PCR alpha beta depletion along with like reduced toxicity conditioning. But I think you use that trio flu and thiotepa, which was myeloablative conditioning, right?
That's right. Yeah.
Yeah, so it depends on whether what do you want in your bone marrow transplant, because if the child is not having any kind of pre-existing disease, and if you do not want like where a complete donor chimerism is required, then use myeloablative conditioning. And if child is already having that pre-existing disease, pre-existing like comorbidities, and if you do not want like full donor chimerism, just like T negative, B negative, and NK positive, then you can use like reduced toxicity conditioning regimen like flu, trio, and all.
Okay, so this family was from a medical background. Both the parents had a medical background. They also had done a lot of research about SCID. By the time we started the transplant, CMV was under control. The child was on minimal oxygen requirement. We decided to go ahead with 3-drug, conditioning along with graphelon. So, Ramzan, would you comment on conditioned and unconditioned transplant? We have heard always from our seniors that do a unconditioned transplant. It sounds very fancy, but really where exactly is the role of unconditioned transplant in today's era for SCID patients?
So now the dictum is there that all IEI patients should receive condition, because there are more chances of B cell engraftment and there are more T cell persistence over a long period of time. Yogi can also, I think, comment on that. So those patients who receive conditioning regimen, those are having those patients who receive conditions are having like better B cell engraftment, less chances of that IVIG replacement also in that situation, and long-term persistence of CD4 cells.
That's right. So this particular graph clearly shows that, if you are conditioned transplant, your myeloid donor chimerism is better. In conditioned transplant, the requirement of IgG is less. And if you have a good myeloid chimerism, the odds that you will not require immunoglobulin replacement is going to be higher. So clearly, conditioned transplant wins over unconditioned transplant. It does depend on your situation and the type of SCID that the patient has and what type of donor you have, but you will have better B cell reconstitution, especially required for atypical skids. And something like an Artemis skid, or these, there can be difficult patients. Those who are NK plus skids, you will need some kind of a conditioning. And if you do not condition, these patients may have decreased thymopoiesis over time. So what is your preferred haplo platform, Ramzan? If you have to choose one, what would be your preferred haplo platform?
So I would choose this. I mean, like TCR alpha beta depletion for sure.
Okay, so this is a beautiful tabular column which shows the advantages, disadvantages, and what are the precautions that we have to take for the TCR alpha beta versus PT Psi. I don't think we have much access to the CD34 positive selection, but in the hospital where I trained in Westmead, mainly those transplants were CD34 positive selected transplants. The TCR alpha beta outcomes from the UK are really encouraging, and I would encourage all the juniors to go through these papers where the outcomes for these patients are really fantastic as compared to all the other platforms you use. About genetic variants and SCID, can we have a comment from you, Ramzan?
Yeah, so as I already told you regarding in terms of T negative, B negative, and NK negative cells, right? So these patients may or may not need conditioning regimen, like they have already mentioned, like C or D or so. But even if like mass sibling donor, few people are using like flu trio in that setting also, because these patients I already told you better in terms of B cell engraftment and long-term persistence of the disease. In terms of NK cell positive, these patients usually require conditioning for sure. And if it is like Omen syndrome, have you heard regarding Omen syndrome? Child is having rash and organomegaly and endocrinopathies and all that. In that situation, these patients, surely it is mandatory to use like conditioning regimen along with serotherapy. So this is
That's
a
right.
very
So,
last
so
stage.
absolutely. So thanks, Ramzan, for highlighting that. And only this paper I actually looked at while reviewing for this, where they have shown that in hypomorphic RAG deficiency, which came to me as a surprise later, these patients, if you use T cell depletion, the outcome was poor. And when you look at the donor type, the mismatched donor had actually really poor outcomes. So this is one to be looked at, these hypomorphic rags and the Artemis, where the outcomes can be quite poor. Luckily for our patient, the donor chimerism has been 100%. The baby has shown good immune reconstitution. And just a word about radiosensitive kids, where you see these types of kids, they can have autoimmunity, myelodysplasia, malignancies. And while conditioning these children, alkylating agents can be, quite life-threatening for these patients. They can have multi-organ failure, early mortality, and something like a Fanconi regimen or a protocol F has been recommended for these patients. Very limited data because this is extremely rare, but I could lay my hands on this one paper with 74 patients where, despite this being a very difficult cohort, they have shown that if you don't give them alkylators, don't give them radiotherapy, you can still have a reasonable outcome. Now, because the topic given to me was also to highlight India and the Indian perspective and the low middle income perspective, I looked at some of the papers from India on immunodeficiency. This was one paper where 57 patients of SCID were brought together, and only 4 underwent transplant. None of them survived. But it was a good effort to bring all patients together and to see their genetics. This paper from Apollo Chennai, where 85 primary immunodeficiency transplants were reported, SCID was one of the important categories, and good outcomes, very good outcomes, published in 2018. And it showed that SCID patients, they struggled with infection, CGD, they struggled with GVHD, and VAS patients, they struggled with immune cytopenias as the main problem. I requested Sunil to share his data, where in 47 patients, they have a big representation for HLH, CGD, and also some kids are there, 6 kids are there. And, they have different types of transplants all put together, very reasonably good outcomes. You can see the overall survivals were pretty good. And they've also done both the platforms for haplotransplant. And these are the survival curves. I requested Ambreen to share some data from Vardia, and these are some of the publications from their team, very good work on primary immunodeficiency. And again, they've shown that with aggressive treatment of infection, management of immune dysregulation, you can have good outcomes even in developing countries. Stalin was kind enough to share some data of 61 transplants they have done for various conditions, and 17 were SCID. And they had just 4 deaths in these patients. And you can only imagine that all Indian SCIDs present so late and in such bad conditions. So to have such good outcomes in India is definitely possible. With that, I move to the next case. Next case is for you, Anand, where this little baby was born out of a non-consanguineous union. It was a late preterm. He was born LSCS due to maternal hypertension, and he was well until 5 months of age when this baby started becoming sick. So there were recurrent episodes of respiratory tract infection. The baby was managed, repeatedly in OPD. Finally, at 9 months, this baby got RSV positivity. Low platelets were noted and was admitted for 2 weeks at that time with the RSV infection. He improved on high flow nasal cannula. Later, he developed bad diarrhea. It was proven to be rotaviral diarrhea. And he had bloody stool, skin eczema, and the platelets were persistently low. That time, somebody noted that these platelets were small, MPV was low, suspicion of Wiskott Aldrich was, kept in mind. Flow actually showed that, the cells were normal, CD8 cells were a little bit reduced, immunoglobulin were not very bad, IgG was a bit low. And because of there was, VAS suspicion, next generation sequencing was done, which showed, the class 2 type of a defect of VAS in this patient. So patient presented to our hospital, Gangaram, with this history. He was commenced on IVIG, kind of supplementation, which he received every 3 weeks. There was no matched sibling or unrelated donor. Now, my question to you is, because VAS can be a very heterogeneous disorder. Anand, what do you think? Should all VAS be transplanted? What is this VAS scoring? And what are the types of mutation and severity, and does that help us to transplant? I'm sorry to put 3 questions, but I'll put them one by one once again. So should all VAS be transplanted?
Sure. Thanks, Manas, and thanks to SPECT for this opportunity. So I think Yogi in transition mentioned this, that for historically we were looking at a group of Wiskott-Aldrich which would present with only thrombocytopenia, and that was the classical X-linked thrombocytopenia, who would not have the other manifestations of eczema, immune deficiency, and definitely not have autoimmunity and malignancy. And the other classical presentation, like what Manas showed us, many of our patients who come to us are like that. They would already have had some features of immune deficiency. They already had bad eczema, and some also come with other types of immune cytopenias. We, in fact, had a child who in the second decade developed a malignancy also. So historically, people felt that if you had a score of less than 3, that is 1 or 2, you could just follow up these patients and avoid transplant, keep them on just supportive care. And once you had 3 or more, you would have to take them up for transplant. So Manas's patient is clearly one who is quite sick and has to get to transplant. Over a period of time, this thought process has slightly changed, because just like in SCID or in so many other primary immune deficiencies, we start looking at genetics to give us a sense as to what's going to happen. People found that over a period of time, even the milder, that is the X-linked thrombocytopenia, started over a period of time, not in early infancy, not before 4 or 5 years of age, but later on they started developing other autoimmune diseases. So overall, people would definitely do early transplant for those with a higher score, but keep in mind that the so-called X-linked thrombocytopenias may also evolve to have other complications.
Thank you, Anand. So, really the spectrum of SCID is actually, diverse, but more and more, I think, we are going to err on the side of doing transplant for these patients, unless you really have a very, very mild phenotype. And in fact, How I Treat article says that we should discontinue this term of X-linked thrombocytopenia, because it kind of puts a false sense of reassurance in patients that, you are going to be all right, nothing is going to happen. only they realize by 18, 19, 20 years of age that they have so many autoimmune manifestations and so many complications, which, at that point of time to manage can be a big struggle. So you all know about these clinical manifestations of SCID, and I will not go into the detail. But my second question to you, Anand, was about these mutations and what we make out of these mutations and decisions for transplant. Is there a correlation for that in VAS?
Right. I think you have this nice cartoon here which shows us on the top box class 1 mutations and class 2 mutations. The class 1 would be primarily missense mutations, and these are known to even currently have a less severe phenotype. Whereas the class 2 would be all the others who would definitely evolve relatively quickly. So rather than look at only the VAS score, there is suggestions to look at the type of mutations, just like what we saw in SCID. You'll decide based on the genetics, what type of conditioning and other things. So it's only this small group of missense mutations which may have a mild phenotype moving forward. So now that we have NGS accessible to us, a lot of genetics work happening in the country, I'm sure we'll be able to risk stratify our viscots better and take children earlier to transplant. Thank you.
Absolutely. And you can clearly see here that in these class 2, the odds that a patient is alive, is much higher
Higher.
as compared to, much lower as compared to the class 1, where, your odds of being alive is much higher. So class 1 is milder, class 2 is more severe. I think this patient fits into class 2. And you can see here in these graphs, clearly the class 2 patients are doing worse as compared to the class 1 patients. The probability of survival is much less. So other medical management of VAS, Anand, already Yogi has highlighted pre-transplant management, but can you just briefly tell something unique about VAS that can be added?
So I think unlike SCID, when you have a diagnosis of VAS, you get some time to get your act together. Immune cytopenias and colitis were already mentioned in the previous talk. And we know that getting some of these manifestations under good control prior to actually starting the conditioning is quite important. I'm sure most of us, when we diagnose a child with Viscot and we are waiting for the genetics, we would have thought of already an immune-mediated cytopenias. So IVIG would be the way to go. Many of these children, while they're waiting for transplant, could be managed with a monthly supportive IVIG management. The other paper, which is quite recent, and thanks Manas for sharing this, is bridging. We've done this for some of our Fanconi's patients, and it's worked well. But this is also true for Viscot, where this paper, I have no personal experience with actually doing this for Viscot, but using either any of the TPO agonists, both romiflostim and L-trombopag, to try and get the platelets up prior to actually going for transplant. It's quite useful because you're not going to give them regular transfusions, and so this has been one of the more recently published data.
That's right. So,
Colitis, I think, yeah, colitis, I think Yogi had mentioned.
yeah.
So for us, I have no personal experience with vedolizumab, but obviously we have used steroids to try and get vasculitis and other autoimmune cytopenias under control. Thank you.
Yeah, so that's the poor man's drug that we use steroids all the time to manage inflammation in these patients. Many of them are treated like ITP, so some of them are already Cushingoid by the time a diagnosis of Viscot Aldrich is made, and that probably brings down their inflammation, but may predispose them for further immune deficiency, which is already a big problem for these patients. So in this particular case, the DSA was negative. Plan was to do a haplotransplant. Very low dose steroid was given for eczema and other inflammatory conditions that this child has. So, if you're going to transplant such a child, what is your counseling going to be like? What is your expected outcome of transplanting VAS, in our scenario?
So, I mean, there is published data from EBMT which looks at age of transplant, and I think that's true anywhere in the world, which has shown that when you transplant VAS less than 5 years of age, prior to their, then the outcomes are superior to children who are more than 5 years of And obviously, you want to catch these children before they've had any malignancy. You would try and obviously get a match sibling donor, but even other donor sources have almost an equal outcome. So I think the age is the critical factor in getting all the inflammation on board in a VAS under control before going for transplant. Thanks.
Yeah. So this is the summary of all the stem cell transplant big papers on VAS, nicely summarized in this tabular column, and it clearly says that match sibling donor is better. But as we know that the outcomes of mismatch and MUD are also improving with time, so why not offer that to a patient where you don't have a much matched family donor? So pre-transplant workup in this baby revealed a CMV to be positive, and we were just beating ourselves to give those steroids because we thought maybe our steroid administration predisposed this child to have CMV, and obviously with a CMV positivity on board, the outcomes become worse. We tried to start this baby on Valg and cyclovir, and the CMV titers gradually reduced because we didn't want to keep this baby in hospitalized for a long time. Unfortunately, the baby again got admitted with 5 days of diarrhea, dehydration, quite severely dehydrated. Got better from that, and then we could take this baby up for transplant. So, Anand, what would be your transplant strategy for haplo? What drugs would you use? What protocol would you use from A, B, C, D, E, F?
Right. So I think EBMT has made our work a little less difficult by providing these options. I think in Viscot, we have to keep in mind that our goal is to get as complete a donor chimerism as possible. Since that's one of the goals, because we know that if we don't get a complete good donor chimerism, a higher risk of autoimmunity post-transplant. I'm sure all of our families would want to see a normal platelet count post-transplant. So if you don't give a good myeloid chimerism, you would continue to have some thrombocytopenia, even though your lymphocyte function may have actually improved and the transplant may have actually helped the child. So look, keeping those features in mind, this group C or D, busulfan fludarabine or triosulfan fludarabine has been used. I am aware of a paper, comparing bu-flu plus minus thiotepa and trio-flu plus minus thiotepa. Each has its own advantages and disadvantages. But overall, what has been shown is that when you use busulfan, you've had better full donor chimerism and less requirement for second procedures like either a stem cell boost or a donor lymphocyte infusion. Whereas if you have a very sick child and you are concerned about giving busulfan, triosulfan could be used, but you would be watching out. We know that in all platforms, triosulfan's higher risk of mixed donor chimerism. So you would be watching out for mixed donor chimerism and recognizing that you may have to do some post-transplant manipulations to try and get your chimerism up. But the goal is to definitely try and get a full donor chimerism. So if a child
That's
is
right.
not very sick,
We don't want autoimmunity. We don't want other complications later. We don't want recurrence of thrombocytopenia. And that is why we want a full donor chimerism in this patient, which cannot just come with two drugs. So probably a more aggressive approach is required for VAS patients, and we do have time to kind of stabilize them and take them up for transplant. This big study, I would like the students to take attention to this study by Albert et al., which showed that the outcomes were really, really good, but triosulfan was associated with increased incidence of graft failure, mixed chimerism, and secondary cellular therapies when it was used in these patients. But mind you, we don't have access to view pharmacokinetics. So that puts across a big challenge for our patients, where if we struggle with complications like VOD or other, we don't even have access to defibrotide. So, we really have to think what is best choice for our patients here in India. And the overall survival for matched donor was clearly better in this cohort, and outcomes for mismatch were inferior. But you can see that with time the outcomes are improving, and from 2014 to 2017 you can see improvement as compared to the previous era. It's very important that in these patients we take a note of the fact, as highlighted, that there is high chance that there will be a secondary cellular therapy or procedure with trio group. It highlights that the odds with bu will be less, and the graft failure will be more with trio. And you can see here the chimerism data with triosulfan being higher higher chances of mixed chimerism as compared to BU protocols, which is very beautifully shown. But despite all this, and with this child being sick, we have decided to go ahead with TTF regimen with ATG and rituximab. We are using a TCR alpha beta CD19 depletion. Started the baby on letermovir, which is now available thankfully in India. We are hoping that it will keep the CMV under control. So currently the child is day plus 10, had very stormy first 8 or 10 days. We have used granulocyte prophylactically for severe neutropenia. We are hoping for a good outcome. So if you get mixed chimerism, you have already highlighted what can happen. So Anand, would you say that should all VAS patients, can we really cure these patients? Can they be free of IVIG? Can they live a normal life after, we have done a transplant?
Yeah, so I think if you've got a good chimerism and your immune reconstitution is good, yes, patients have a very good quality of life post-transplant. I think one point which I forgot to mention in conditioning for the students is that most VAS transplant, because you have an inflamed patient, you would add serotherapy. So a lot of teams, even for match sibling donor, would add serotherapy, which is a little different from other platforms of transplant. Thanks.
Yeah, and let's hope that gene therapy can make the outcomes of these patients better. So a lot of work is being done, and this is beyond the scope of this presentation. So I'll just skip this and just highlight a little bit on the Viscott Aldrich and what India has done about it. Again, multi-institutional data for these patients, and you can see XLTs did better than the classic VAS. Overall survival, you can see it's not bad. You can see the transplant probably was done very late for these patients. So, it probably kind of looks similar to conservative, but definitely we need more data for that. And, this multi-center outcome paper, which is a very important paper, I can see all the prominent names here who have, contributed this data. An important subset of patients was Viscott Aldrich and CGD. I think because, kids don't reach the stage of transplant, and that is why our data may show less of skids, because by the time they reach us they are not in a good condition. But I think it's just heartening to see the type of papers that have come up. I can see Dr. Yadav's paper with PT Sai, from Delhi Apollo. I can see papers from Army Hospital, all highlighting excellent outcomes for patients with Viscott Aldrich syndrome. And before 2016 and after 2016, we can see the dramatic change of outcomes in PIDs, which kind of tells us that India is not doing that bad. So Yogi, after that little slumber of yours, we'll get you back for this last case, probably one of the most difficult ones that we managed. And not a great outcome for this baby, but we want to learn from you and see where we faltered for this child with CGD. So this is a 9-year-old boy case of CGD, NCF1 mutation, history of pulmonary tuberculosis. The Western data may not show, but our PIDs, there is so much tuberculosis, which can be a big challenge for us. Even the XLAs have tuberculosis. So, in this patient, there was pseudomonas, serratia, multiple valves done at different centers, required tracheostomy. So he came to us and, he had a tracheostomy in C2. He had a recent RSV pneumonia. And, really, we were shaking to take this child up for transplant. Pioglitazone was tried, it is tried for some CGDs. It helps, it doesn't help. I really don't think it helps much. Itraconazole, Septron prophylaxis, non-availability of HLA mat donor, but we were lucky to get a Datri donor. A fully matched transplant was possible. Now, the CCT was not good. The child had bronchiectasis and all the other problems. So, when you look at such a patient, what would be your response?
Yeah, first of all, I'll pray to God.
Yeah.
Yeah, so I think this is a really challenging and tough case, correct? Like, and this is the issue because with these many comorbidities, like what are the chances and what are the guarantee of success? They definitely boil down. As we had looked, like if somebody has infection coming in, and this kind of infection like pulmonary tuberculosis, or is already the lung is damaged, there's no measure of how much lung has damaged. Like you can do a CT scan, but it cannot tell you the actual damage which has already happened there, correct? So very tough case. And then
Yeah.
NCF1 again, they can present with bad autoimmunity, which we sometimes we think okay, NCF1 okay, they can definitely give you more challenges than even the X-link sometimes. So that is really important. And as we can see here,
That's
like
true.
even the kids with the mutation P47, just to point out that there was a gene therapy trial which was open for just for the P47, which they had to close prematurely. They only treated one patient. We were part of the trial, but eventually we did not enroll anybody. The reason why they closed was because this company was doing prime editing for P47, and they found that closing the trial is much better cost effectively because they will not be able to find much patients who will be
Hmm.
ready for this. But
Hmm.
but that is probably the future in picking them up early. But this is a really challenging case. Yeah. Uh,
Okay.
Also, if
So,
we look at the oxygen, uh, correct, like if you have some residual oxygen capacity, like then you have probably better outcome. Again, like this is not what we see sometimes in our experience, correct? Like this is good for the data, this is good for the trial, this is good for the studies, but this will not be truly reflective of what your outcome will be post transplant.
so
uh,
Yogi, would you say that every CGD requires transplant? We hear
yeah.
that this is less severe, that is less severe, this has more reactive oxygen intermediates, that has less reactive oxygen intermediate. But what is it? Should we transplant
so i
every
can
CGD?
so I can tell you, the NIH was strong opponent of no transplant in any CGD, and they have now moved to transplanting everybody with CGD, because what they've seen is like long term, like when you look at these patients, like they may not have that long term survival gets impacted. They develop autoimmunity, they develop colitis, they have recurrent hospital admissions for infections, and one day one of the infections will kill them. So that is the issue. Which patient, we don't know.
Yeah.
And 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 then that's why when we think of X-linked CGD, we say, okay, yeah, easy decision. But for the other ones, autosomal recessive, we always think of, okay, should I take him to transplant? Should I not take him to transplant? They're less symptomatic. But probably that is the time where you can try if you have a donor available when they have less comorbidities. Yeah.
Interestingly, I'm not sure if I put that slide finally into the slide set. As compared to the West, India has more of autosomal recessive CGDs,
Correct.
and that is
Correct.
probably because of the consanguinity, which is supposed to be milder. But again, because of more and more infections, I think we end up having these very severe forms of sick patients that we see in India with the chronic granulomatous disease. And I think it won't be wrong to just recommend every CGD to undergo a transplant. There can
And
only be few of these with like activity positive patients where they might just do well with the antibiotic prophylaxis. So I'll just highlight that these 39 X-linked CGDs, again, Western data, they had much more severe disease, they had much poor outcome. And this 91-0 CGD, which included 33 patients, significantly earlier onset of disease. And you can see here that these patients had presented at 1 year of age as compared to everyone else who started presenting at 4 or 4.5 years of age. And autosomal recessive were supposed to do better, and this is significantly shown. So to transplant or to not transplant, I think there is this a paper which compared 30 versus 32 transplant or non-transplant patient. Survival in each cohort was 90%. But if we really look at the quality of life, the morbidity, the inflammatory complications that this another paper highlights for long-term outcome of patients with CGD, I think probably worse health related quality, emotional well-being. So the tendency is towards transplanting everyone with CGD. So am I correct in saying this, Yogi?
yeah, that's true. And then important thing, like I can tell you about Canada, like we don't have any adult transplanter in for CGD after 18. So
Okay.
this is a very common problem which we have, like when to take them to transplant. Is it the right time or not? They're less symptomatic. And these decisions also depend on like what will they do when they're adults, because there's nobody who is transplanting them at adult, correct? So we tend to favor transplant, especially early. The NCF ones, they will be late in presentation. So that's why like your patient had already bronchiectasis, already had lung damage because of the recurrent infection,
Yeah.
and it's very difficult to diagnose them upfront because
Yeah.
the symptoms are so mild. So but it should be high on the radar, simple testing just to make sure that and then pick them
Yeah.
up early is the best way moving forward.
Yeah, so this was like, kind of the criteria for transplanting CGD. I think we're kind of moving away from this. This was in 2017 that, if you have one of these criterias, you probably need to transplant these CGD. So, Yogi, what is the ideal age for transplanting a CGD?
So the X-linked CGD we transplant as early as possible once the diagnosis is made, and then for the NCF1 you have time in hand. However, if you see uh, when they put these cutoffs, I don't like that because all these cutoffs are telling you that the patient is more sicker, and that's why at this cutoff they found that less sicker patients did well, which is true. Like if you don't have comorbidity, you don't have colitis, you don't have bronchiectasis, then you will do best with the match sibling donor transplant. You can put that cutoff at 5, you can put that cutoff as 3. But the key message is you have to pick them up early. You have to pick them up before the bronchitis, before the colitis is into picture. Correct. So that is the key point. And then you can take 100 patients and then you can say, okay, my cutoff is 3. I got a good result, and this is what it is showing. My survival is better at 3, and this is what I will tell the world. But this may not be truly reflective. Correct. And
Yeah,
if
it's just good for the graph for the patient. I
correct,
think sooner
correct.
the better.
Yeah,
We should transplant. And if you look at the outcomes of adult patients with CGD, it's really
correct.
not very bad. So it's not that bad. So but it is definitely inferior to those who were transplanted in childhood. But I think why wait? Why have all these problems? Why give them so much of toxicity of all the antibiotics and recurrent admissions, and if safe transplant can be performed for these patients, it would be better to do sooner rather than later. Any specific pre-transplant workup specifically for CGD that you would recommend?
Yeah, so what we do normally do is definitely we look at the lungs. We definitely will have a baseline CT chest. The benefit of that is because if they get infection post, it's very, very difficult post transplant to say whether this is a fungal infection or not, unless only you have a frank, clear sign of aspergillus or aspergilloma, correct? So once you have that baseline picture, you know, okay, this bronchiectasis is my baseline. This is the baseline issue. When you do post transplant evaluation for infection, then at least you have something to compare. If you directly come in and you have not done any baseline investigation, then you will land up in trouble. For kids who can do PFT, advises get the PFT done, because that is another important lung function. They are at risk of chronic GVHD. They are at risk of BO in future. So that will also help you. For GI tract, definitely, if they have colitis like symptoms, you will try to control the colitis. You will discuss with your GI colleagues. If you want, you can go for the colonoscopy. Not ideal, but yeah, like it all depends how far you want to investigate. But definitely, stool calprotectin can help you. Ultrasound can help you in bowel wall thickness. We don't go for the biopsy in each and every patient. Definitely, if possible, find out if the stool multiplex is negative for infections. So that is also key. And then for the kidney, sometimes we do see damage. We had a patient with CKD, with CGD. So those definitely make sure that there's no urinary protein, there's no protein loss from the kidney. So that is what we
And
do.
Yogi, what about BAL? Should it be done universally for all children with CGD who have a lung disease? Should we do a BAL before transplant?
It depends on what you want to achieve from that BAL. If the kid is asymptomatic, then probably you will not achieve much, correct? But like in your case, like you had frank TB, you had RSV, so you can say whether I want to make sure that I don't have active tuberculosis at that
Active
time point.
infection. Yeah.
So then it may be beneficial, but not for everybody. Yeah.
Yeah. So this child actually had tuberculosis in the first BAL, and that is why the transplant was in fact delayed for this patient, and it was picked on culture and not really on the initial testing. So this clinical status before transplant is very, very important. If you have colitis, if you have liver derangement, your outcomes of transplant are going to be inferior, and we have heard a lot about that from Yogi in his first talk, and it was really nice to see that this work on by our Indian colleagues from Apollo Chennai. They actually looked at transplanting this very early onset inflammatory bowel disease patients, which included CGD, VAS, KID, all these patients, and really good outcomes by I think a multidisciplinary management. Despite we don't have access to many biologicals present. Now, interestingly, I want your comment on this, Yogi,
Yeah.
because this paper really says that if you have infection, it doesn't matter. Your transplant
Yeah,
outcome will be good. If you have IBD, it
correct.
doesn't matter. Your transplant outcome will be good. Isn't this contradictory to what we have always been thinking for these patients?
Correct. So this is true because this is North American data, and then I was in the same meeting when they were discussing this, and then this was the worry when this paper comes out. Then the reflection all to the world is it does not matter if you have infection, does not matter if you have colitis. So I think the important thing here is all these patients who had colitis, they were very well managed pre-transplant. That is not reflective on the paper. They had colitis which was controlled. So that is why it does not matter. If you have a worse colitis, you're not controlling it, definitely that will have an impact. That is not reflective on this paper. So all these patients, they were on 4 or 5 different kind of agents to control their colitis before they took them to transplant. So this is important point to highlight. Regarding infection, again, what kind of infection? They did not have tuberculosis.
Yeah.
So which can impact, correct? Was it a viral infection? Was it a bacterial infection? If you have staph skin infection, staph abscess, you will not have that kind of worse outcome. You can still manage them with the antibiotics. So that is not really what they were talking about, correct? Because in Indian scenario, you can have viral infection, you can have other infections, and that can definitely have an impact. So this
And
paper,
many of
that's
them may
why,
be multi-drug resistant, and we don't have
correct,
access
correct,
to all these
all the
biologicals. So,
correct. So
it
this
looks
paper is
very
not
good, but
correct. This
it
paper is
really
not
probably,
reflective
yeah,
of that
true.
part. Yeah.
True. But, can you comment on this Rick versus Mac for,
Yeah.
CGD transplant? Because I think that's also a very important point to discuss in these patients.
So the thing is, the North America, apart from Canada, they don't have the triosulfan. So whatever they're doing is they're doing busulfan based conditioning for CGD, and that can definitely have an impact on overall survival because you can develop VOD. And then this is historical data, correct? They have been using busi as their base regime instead of the trioflu or triofluci, which normally the Europeans use. So that's why that difference is there. If you see that the donor choice did not make much impact, the important thing which comes out of this paper is if you have IBD, if it's controlled, it takes time for the IBD features to go away. But at the end of 2 years, almost everybody was cured of their IBD. So I think that is one thing which comes out of this paper, that in CGD, the colitis will be cured, but it will take time.
So, this is just, kind of looking at donors for CGD. So, what would be
Correct.
an ideal donor for a CGD patient?
Yeah, so as we all know, like it's for any other condition, correct? Match donors will be the best. And if you start going down with the mismatches, then definitely your outcome is impacted. However, there's a new haplo paper, and I know you have already put that in the slide, which also shows that the outcome can be decent even with the haploidentical transplant and CGD. Not much has been done in that front, but Europeans are doing, and then there are only very few patients from the North America.
That's right. So, this is, a very recent paper on haplotransplant for CGD, which actually says that, outcomes with haplo is much better. And for the younger colleagues, I would encourage them to go back and look at this paper, which actually talks about TCR alpha beta. It talks about PT psi, how to transplant these CGDs, because really speaking, haplo donor is the most common donor that would be available for most of our patients. And the outcomes as per this paper for PT psi were actually better than TCR alpha beta. Yogi, your comments on that?
Yeah, I think this is their local experience, correct? So every it like every center has their own expertise. We are not a TCR alpha beta expertise center here in at SickKids. We are PTSI center. So that's why when I presented, I showed you the PTSI patients in the Vidlozumab paper. But yeah, like every center has their own. So go with whatever your experience is, whatever you are best at doing, and then try to get best outcome from that. So both the strategies are good strategies. And Europe
And
is like
yeah.
equally divided because there are some centers who just do TCR alpha beta, and then there are some centers who just do PT psi. Yeah.
Okay. So, graft failure was a big problem still with haplo. GVHD was a big problem, especially with PT psi. So, I think we need to choose the poison carefully as to what we want to do for our patients. It did show that, when you were talking of TCR alpha beta, Trio was the drug that was commonly used. If you're doing PT psi, Bu was the common drug that was used. And I hear from you that you use PT psi, but you use it with Trio. So that's
Yeah.
again an interesting combination, which is different from what the Europeans have been doing traditionally. Now, we for this patient used flu, trio, psi as per recommendations from our international colleagues. We did not have a very good outcome. This boy had a bad veno-occlusive disease and a pulmonary hemorrhage, and could not, tolerate this transplant. And I think it was taking up a very sick child into transplant, and clearly we didn't have a very good outcome. These protocols are all out there. What we want to use for our patients, but especially in CGD, it may be a case that we are okay with not a full donor chimerism, and it may be fine to use protocol C and D, which is less myeloablative as compared to A and B, and less toxic as compared to A and B, where more drugs are used, and a less myeloid chimerism may be enough. But again, when we use lesser drugs for these inflamed patients, we are very scared of graft rejection, because we have not really taken their own immune system out. We try to add serotherapy, but we are worried that we may lose the graft, and that is something again we are very scared of. But if you get a stable myeloid chimerism for these patients, you may have actually good outcome. And trio based conditioning also, there are papers to show that it can have reasonably okay outcomes for patients with CGD. I won't go into details, but we need to look out for a macleoid phenotype in these patients, where they can be, if you transplant them from KEL positive donors or transfuse them from KEL positive, they can have a lot of hemolytic issues. We need to be wary of these X-linked carrier mothers, and using them as a donor, because that can again transmit the disease, and you may actually not be able to correct the deficiency properly. And we also need to know that these X-linked carriers may be candidates for transplant themselves, because they may develop symptoms later in their life that are not really manageable by conservative management. And again, those transplanters will be needed to transplant these adults who have these complicated manifestations. The DHRSA can be a good test post transplant to kind of look at the activity. It's a simple test available at most centers and does have a role in these patients. And again, lesser chimerism also may be okay for patients with CGD. So to summarize this whole discussion, we took 3 prototype cases. We looked at some flavor from India as to what India is doing in terms of transplanting these PID patients. But I would just like to say that PID is a very heterogeneous group of disease. Individualized approach is needed. Pre-transplant planning is very crucial. Management of these complications is very crucial, but we have to also balance it with when we are going to transplant, because we don't want to delay the transplant so much that the patient gets into an organ damage and the outcomes are bad. So LMICs, including India, are probably on the right path to face the big challenge of these extremely difficult cohort of patients. And I think the efforts like what SPCTT or ISBMT are doing by education and meetings and everything will hopefully improve outcomes for these patients. Thank you so much for this opportunity, and I thank all the panelists for their wonderful participation.
Thank you.
So thank you very much, Manas. I think we wanted to go on, and it's been a very interesting discussion. And I think you have really discussed the very prototype cases and real ground challenges. And thank you very much for the interesting discussion, all of you. I think we can take a couple of questions. I know we are way beyond time. But there were 2 questions. I think Anand itself has asked what are any specific.
Sorry, I do apologize. I have to.
No problem. Yogi, you can log off. Thank you very much for joining.
Thank you. Yeah, thank you so much.
The one Anand itself has asked is any specific IEIs where PTCY should be chosen over TCR alpha beta. So you have to answer it yourself, Anand.
No, the reason I asked is that I think in IEI, like already presented today, it's a kind of confusing. The data also is a bit confusing. And I know there are students, I don't know how many students in the audience, because most of the people are actually already doing transplants. Anyway, that's a separate issue. So the reason I asked was like in some situations like Fanconi's haplo, we always prefer T-deplete. So I was wondering whether, there could be any models in inborn error of immunity where for affording patients, we would definitely say, no, let's go for, I know for the very young babies, less than 3 months, less than 6 months, we would go for that, where we don't want to give high dose cyclophosphamide. I was wondering whether there are any other older patients where you would go for alpha beta depletion, or is it more just experience? Thanks.
So I think, if I'm permitted, one is of course age. Younger babies you already mentioned will try to avoid cyclophosphamide. Second is also what comorbidities they're having before transplant. If you're having a child with sepsis, fungal infections, you want a early count recovery, and you don't want to give them, cyclophosphamide post graft. So this is another group of patients who will want to go for a TCR alpha beta. At the same time, as has been highlighted by all of you, that IEs always are not immunodeficient, right? So there's a very large group of patients who are so-called immunocompetent and sometimes hyperinflamed. And these are the patients who actually will have a higher rejection risk with a deplete graft. So that's also something to keep in mind. And some of those patients may be better with PTCY actually, because the rejection rates are lesser. If you are too inflamed, or if you're too overly immune kind of competent, as compared to the skids, for example, where engraftment is easy and you want early engraftment, which T cell alpha beta probably will do. So I think that's probably some of the things which are, except for in addition to finances, which play a role. I think there's one more question and we'll close after this, and that is, how do you deal with massive spleen in CGD, WAS, CVIDs, particularly for haplo-BMT? So, Manas or Ramzan or Anand, any one of you can take it.
So I think splenectomy has been advised for few CGDs before transplant. But again, you have to balance it with the risk of rejection, infections that can come, it can bring along with. And, in fact, some of these VASs and others also, people have tried splenectomy. So, I think that is one possibility if the spleen is really large. But again, this is going to be a very difficult scenario to manage, considering the fact that some of them are immune deficient and they'll need longer prophylaxis of antibiotics, in the future.
Okay. So, thank you all, and thank you very much for joining today. And it's been a very interesting session today. We are the immunodeficiency capital of the world. There's estimation that 100,000 children in India are born everywhere with severe immunodeficiency. So I think we are diagnosing more and more now with better diagnostic facilities. I think this is the field which is, of course, going to be evolving, and we'll have to deal with more and more of them. And I think as time goes, we'll have more cleaner cases, as the index of suspicion is higher, and our pediatric colleagues are more sensitized in working up some of these patients and diagnose them early. Thank you very much, and we'll see you again on 29th of July for the next month's webinar. Stay tuned for more information on that, and good night, everyone. Thank you,
Thank you,
Satendra,
Sunil.
for